Welcome, everybody. Glad to see you strolling in.
Just for time, if everyone start to introduce yourselves in the chat, that'd be great, and we'll go ahead and get started.
If you have questions, also put those in the chat, and we'll let Duane catch them as we move along. So, ready, roll? Duane, please.
Hello, and nice to meet you all. My name is Duane Pearson. I'm the practice director for rheumatology at the University of Colorado on the Anschutz campus. And I'd like to thank the Aurora Health Access team for inviting me to talk a little bit about rheumatology and some of the population health aspects of rheumatologic disease. So rheumatology is actually, rheumatology is an ancient field that actually just started to be relevant in the 1930s. So rheumatology, rheuma is one of the four evil humors. Now, we really don't believe in the four evil humors still, but it is germane to the name. So rheuma is the evil humor that comes from the brain and the spleen lodging in skin and joints, causing disease. Historically, the other three humors are heme, black bile, and yellow bile. So I am very grateful to be one of the few humorologists out there. Hey, Rich, when I do these, could you give me a little bit of a drum roll, please? It would be great. Really anything that causes inflammation affecting multi-organs that is related to, because what we know now is the phlegm is just the immune system. So anytime the immune system causes multi-organ disease, and it is still usually manifest with skin rashes, joint pain, but then we'll also throw in the concept of organ failure. So some of these things that actually land in the purview of a rheumatologist include things like lupus, rheumatoid arthritis, gout, spondyloarthritis like ankylosing spondylitis, and diseases that cause inflammation of the blood vessels or vasculitis. That's kind of what we do. But now the next thing is, given that this is somewhat of an esoteric field, and what I really want to talk to you about is why is it, as a provider, is it so hard to actually have people get in with a rheumatologist? And I have some answers, but then also I would like to update on what we're doing on the campus to try to address what is actually a national problem. So what is happening with rheumatology access? There is a general dearth of rheumatologists in the Rocky Mountain West. Now, if you look at it merely from the Front Range, there's no problem. We have ample rheumatologists in Denver, Fort Collins, but as soon as you get down to the Springs and South, and as soon as you get past Golden, and also heading out east and the other way, you can go hundreds and hundreds of miles and not find a rheumatologist. And this is a national problem. So when you have a shortage of providers, access becomes more difficult. And I'm going to go into a little bit about the supply and demand and what we're seeing, and then how we're actually using a change in demand. How can we actually change the number of patients that need to be seen because we have so few rheumatologists? And then I do want to have a little bit of an open discussion about changing scopes of practice, because somebody has to care. If we can't care for everyone, who else can we partner with to care for these patients that have what was historically need for rheumatologic care? Can we actually change the scope of practice in the primary medical home? How can we leverage health information technology to try to meet patients where they are, as well as change the demand side of the equation? So good help is hard to find. We've done actually 2 national reviews on what is the supply of rheumatologists compared to demand. In 2005, we did one and we said, oh, we're heading for trouble because by 2020, we're going to have a 30% shortage of rheumatologists. Well, then we redid this in 2015 and said, hey, have we made any difference? And then we realized, holy crud, no, things are actually worse. By 2025, we are going to have half the number of rheumatologists that are necessary to care for an aging population. With age, you have an increased frequency of arthritis, but you also have an increased frequency of autoimmune diseases. And autoimmune diseases across all ages are increasing in awareness, diagnosis, and the need for treatment. I don't even want to get started about 2030. I might have to retire early because in all honesty, we're getting pasted. This is the United States broken down by region. You typically need about one rheumatologist per 60 to 70,000 patients. We're not doing too bad in the what we would call the Southwest. But even in 2015, we were still having to care for about a 10% above what we should be. By 2025, once again, it's twice the number of patients that we have rheumatology available. We can't do it. Now, there is an asymmetry across the United States as well. Up in the Northeast, they're doing pretty well. Eastern Seaboard, they're doing pretty well. But anything heading out towards the West, and then the distribution in the West of rheumatologists, and all these are little rheumatologists all across the country. There's only about 4,000 of us. All of these are where we have. Now this one dot that's over there in Grand Junction, well, that's actually a smaller dot now because the one rheumatologist in Delta that was actually making up for the fact that Grand Junction only had half of a rheumatologist, well, she moved to Nevada. She's probably this dot over here. So look at these in massive swaths of area in our state where you just don't have a rheumatologist. Now, if you're sitting in Aurora, as all of you are with the Aurora Health Alliance, you're saying, wait, I don't really care about the rest of the state. What are you doing for me, man? You're up in that big, beautiful campus. Why aren't we getting people in? Well, so I think I covered this early on because at the request of our fine audience, but really what we're trying to do and who needs us are folks with autoimmune diseases that are multisystemic, inflammatory arthritis. Historically, we've taken care of non-inflammatory arthritis, but I'm going to make an argument that those things need to change. Diffuse and local soft tissue disorders, and then there's a lot of mimickers of rheumatoid arthritis that a rheumatologist needs to be involved in, because if you come in with an arthritis and people don't understand that it's actually due to a lymphoma, your care has been harmed. So there are over 200 rheumatologic disorders and over 140 forms of inflammatory arthritis. It is unrealistic for any primary care provider to know all those things. But how can we leverage what's in this not well-packed brain, but it's okay when it comes to rheumatology? How can we leverage that out in the primary medical home? Or what I'm going to argue for as a concept is the virtual medical neighborhood, because I can't get everybody through the door on campus, period. And I'm going to go over those numbers. So one of the things we have to get comfortable with in America, for years we've been talking about no socialized medicine. We don't want to be like Canada because it takes forever to get healthcare. Guess what? It takes forever to get healthcare here, period. And so we have tried to use free market, and in free market, you would anticipate that if you have demand greater than supply, that you would have growth of your supply. I've already shown you by straightforward numbers, that is not happening. In fact, it's getting worse. So the idea of free market in healthcare, and this is a whole different talk, and I'll fight anybody that wants to about this, it's not realistic, period. Trying to govern your healthcare, the healthcare market as a free market is impossible. So what happens then? Well, you have de facto rationing, period. Not everybody can get in with the specialist they need. And that is sad. I wish it weren't that way, but the sooner we get our heads around that, the more change that we can make. So in rheumatology, what we need to actually do is not focus on mechanical disease like osteoarthritis, not focus on widespread chronic pain syndromes, because I can't fix them any better than a primary care doctor. What I can do, and really what I can make a difference in, is identifying people with inflammatory arthritis or multi-centric or multi-system autoimmune diseases, get them in as early as possible so they don't have permanent and progressive damage, get them stabilized and get them back in their primary medical home. So number one, to be able to address this demand excess, we have to start saying, okay, who can get adequate care in the primary medical home? And then secondarily, we need to be good partners with our friends in the primary medical home to start talking about how can you redesign your primary medical home to, number one, embrace and bring in the virtual medical neighborhood, but also address these challenges. So if we actually look at rheumatology as being defined by intention to treat, who I would say needs to see a rheumatologist, somebody that needs a disease-modifying anti-rheumatic drug. These are high-risk medications that can lead to permanent damage if not used appropriately. Steroid-sparing agents. So somebody is stuck on corticosteroids for things like gout. That's bad for a patient. And if a primary care doctor needs help, we get those patients in as quickly as we can. And then hazard modification. What's happening in terms of the disease or the treatments that could be done better? So if you look at the history of rheumatology, we've done a lot of things with non-inflammatory disease, mechanical disease, widespread pain syndromes. But now there are other specialists that can actually do that. You know, the field of physical medicine rehabilitation, that's even newer than rheumatology. Pain specialists, newer than rheumatology. Leveraging OT and PT much more effectively, much newer than rheumatology. And they have other ways of addressing these diseases that historically have been referred to the rheumatologist. So if you think about a coned down view of this, it's actually 40% of the adult population has some form of chronic musculoskeletal condition. 1 out of 6 visits to primary care is some type of musculoskeletal condition. We have 4,000 rheumatologists, we can't see them all. But then when we start looking, if you start looking at 1 out of 12 women have some, or 1 out of 20 men have some form of ongoing inflammatory disorder that a rheumatologist can treat, we can actually start to make inroads there. We still won't be able to see everybody, but at least we'll get some inroads and cut down wait times. Wait times on the Western Slope right now, somewhere between 6 to 9 months to see a rheumatologist. Colorado Springs, and that's regardless of insurance. Wait times in Colorado Springs, about 4 months. We're a little bit quicker than that on campus. So the challenges we face is how do we leverage and partner with the primary medical home to help differentiate presentations? Everybody's presenting with joint pain. Everybody gets kind of funny rashes. How do we actually help delineate this is somebody that actually needs treatment from a rheumatologist versus this is somebody that needs treatment from another specialist? And then also help partner in the primary medical home to be able to improve our early disease identification, because that improves quality and probably decrease costs, thus increasing value in healthcare. And that's one of the lenses that we have to continue always looking at these changes. So what do we see historically versus what we could delineate now? Primary care clinic, osteoarthritis. I mean, I have no treatments for it. And I can work with primary care providers on how to treat things like osteoarthritis, mechanical back pain, gout, trauma, tendonitis, bursitis, central pain disorders. What we really need to make space for in a rheumatology clinic is rheumatoid arthritis, and the sooner the better, right? Improve community screening for rheumatoid arthritis, get early identification and early treatment, because those patients are going to end up maintaining employment, having a higher quality of life with less cost, value. Lupus and other collagen vascular disorders, inflammatory spine disease, differentiating that from mechanical back pain, something that can be done in the primary medical home, and we can partner in that. Gout that's refractory to routine therapy, inflammatory muscle disease, vasculitis, osteoarthritis, if there's a question, if there's something else going on. So what is the overall scope of all this? Well, let me give you some numbers. 52 million Americans living with rheumatologic disease, but only, by defined traditionally, but only 7 million Americans living with the inflammatory rheumatologic disorders. So already we can improve access if we change a little bit in the definition of who needs to see a rheumatologist. Rheumatologic diseases, if not treated appropriately, are the leading cause of disability in America. We have to see the right people to keep them working and keep them having a fulfilling life. Nobody wants to see patients on disability. There's $8 billion in direct medical costs that go to rheumatology, that go to rheumatologic patients. 80 billion. We can improve that. We can improve that by early diagnosis and early treatment. $47 billion of indirect costs, so things like loss of earning. The average rheumatologic patient, if untreated, takes 15 years off their lives. So there is the acuity out there that we need to get in. But right now, as a field, we're not succeeding. So what are our resources at the University of Colorado on the campus? We have about 5 to 6 CFTEs in an 8-room clinic. That's what we got. We have more specialists listed as part of our division, but the majority of those are researchers that spend a half day at most in clinic. So we have about 5 to 6 clinical FTEs. Comparing that to some of the larger private practices, we're about a third of the size of one of the larger private practices here in Denver. We get over 5,000 referrals per year. We have the capacity to see about 2,500 referrals a year. So our demand outstrips supply by over 200%. Even with those challenges, last year, by partnering with the state and the school, we were at 4 CFTE. We got it up to this 5 to 6 range, and we were actually able to increase the number of patients that we saw by 20% last year. One of the things that as groups in the community needs to realize, and what we're working through, is that we will never, based on space and provider availability, never be able to meet the demand if we continue the historic processes of care delivery. But I have an audacious goal. This is what we're working on. This is what gets me up every day. Why not? If I can't win the game and get everybody in to get care in the traditional face-to-face on-site healthcare delivery model, why not change the model? Change the rules. So that's what we've been working on over the last few years. So if you think about it, there's other ways to provide healthcare. We can do virtual visits. And actually, since COVID hit, they've changed the billing model. And so now you live in Gunnison, I'm going to see you at home. That's fantastic, right? So we have in-person care, and that has its pros and cons. It is the traditional form of healthcare delivery. Everybody's used to getting an exam. I'm used to examining people. I have great data when somebody's on site, but it's also one of the most costly forms of care. It is inconvenient. When somebody drives from Durango up to the university to be seen, it costs them out of pocket about $600 in travel, in housing, time off of work, finding childcare. And that's not even including the bills that they might face if they have one of these stripped down healthcare plans. So we can meet patients where they are by leveraging telemedicine. And I'm going to show you how we've grown that. But then also, how about these forms of indirect care? How about care where actually I'm not directly providing care to the patient, but I'm collaborating with a primary care provider to provide care through their lens in their clinic. And that would include eConsults and Echo Colorado, two things that I've been very passionate about for the last few years and very happy to share what we've been doing. So virtual health visits and outreach clinics, we're doing both. One, the virtual health visit is actually patient at home using a smartphone, mine's all plugged in, computer, and I'm in the office, but actually I don't need to be in clinic. And so if I only have 8 rooms, I can be somewhere else on campus. I can be at home and I can be seeing that patient, which opens clinic rooms for other providers as we can bring in other providers. And that patient's at home, and we have to work through is, are you an appropriate patient to be seen remotely, right? And so we still need to define, who is it safe to actually say, yeah, stay at home versus, no, I got to see you. Then we also have to look for resources in the community. How are they going to get their labs, radiographs? What if something's off? And I'm also a little bit data blind. I don't have vital signs. Once again, it's harder to get labs. But it's a great experience for providers and patients. Saw a guy yesterday from down in La Junta, and he's like, yeah, my hands are feeling much better. I changed up his medications for his room. I saw him on site, said, your arthritis is flaring, going to change your meds, go get labs, and I'll see you in 6 weeks. You stay in La Junta. I'm going to be at my room. And actually, this is not a filter. My room is blurred like this. It's really weird. Rich, that's where you go. So, and he's at home. I got to meet his dog. And then he actually showed me, he's like, my hands are feeling much better. And he shows me I never knew that he was an artist. And he shows me the pictures he's been drawing. That would have never happened if he was in clinic. I love that. But still, there's some data blindness that occurs. But we do help patients because we decrease travel, we decrease their transportation. Now, there are some barriers that we create though, right? So we're addressing some of the barriers to care, but we've created new barriers. Not everybody has the bandwidth. Not everybody has the technology. Not everybody's technologically savvy. So when you're working with the patients, you have to identify who's right. So that brings us over though to outreach clinics. How can we partner with safety net hospitals in rural Colorado? And we have one up and running. We are looking to partner with 2 other ones that we're kind of in the development phase. But when you're partnering with another hospital, you actually have on-site labs, radiology. You have staff that can turn on and off the camera, staff that's there to do vital signs and do physical exam. And it helps those rural hospitals, which are all being threatened with being closed, because they capture facility fee and all the downstream revenue that I don't think UC Health needs to capture, right? So they get the money for the x-rays, they get the money for the infusions, physical therapy, all the things that I do to keep that patient happy, healthy, and working. So we were doing outreach clinics before COVID, but with COVID, and actually this is an initiative that I led as the medical director for ECHO. On March 13th, 2020, I think y'all remember that, we were told we're closing down the state. My provider said, no way. They said we have to maintain access because our patients need us. What are we going to do? So we partnered with our virtual health team and said, okay, how can we rapidly scale virtual visits to home? Because we already knew those were going to be approved by the federal government and those were going to be approved by the state. But we had to train up staff, we had to train up providers, and we had to train the staff also to train patients. So the week before, so the first week of March, the University of Colorado system had done, I think it was somewhere between 50 and 100 virtual visits. We started training on March 16th, 2020. By the end of 2 weeks, we had trained more than 1,500 providers and staff, and then that staff had trained our patients. And within 2 weeks, we went from less than 100 virtual visits to over 2,996, almost 3,000 virtual visits per week. Per day. Per day. Now we've actually backed off on that because we're opened up, but across the campus, it's about a 10 to 15% of of total care that's occurring virtually, through synchronous home visits. That 15% is actually actively being backfilled by patients being seen on site. We created new space by just simply educating people. So that's how we're trying to leverage virtual visits to try to increase space. Now we still need more providers, but we can work on that. Now, one of the ways to actually get more providers is actually leverage what I know in a virtual medical neighborhood. And one of the keys to developing a virtual medical neighborhood is eConsults. So 3 years ago, after doing a pilot in 2015 with HICPUF, the campus said, you know what? We think eConsults are an important tool. So we partnered with the American Academy of Medical Colleges, the AAMC, to partner with them as in the CORE project, which is Coordinating Optimal Referral Experience, which is basically saying, okay, we get the idea. Not everybody needs to be seen in person by a specialist. But how do we define that? And then how do we actually just not say, I'm not going to see that patient, but let me give you some advice or let me work with you. And that's where an eConsult or an enhanced referral helps. Enhanced referral basically just says, this is the data you need to gather based on this template for the diagnosis you think you have. Send us that template, send us the data, we'll review it. And if we need to see that patient, we're going to get them in. But if not, then we're going to actually respond back and give you some ideas on how you can manage other diagnostics that can be done, or a referral to another specialist because that patient might get better care there. So over 3 years, the university has onboarded 26 different specialties. Initially, it was within the confines of the medical school and the medical school clinics. Then we opened up to some of the other UC Health associated clinics. But now we actually have the technology to go in and partner with other EHRs. And so that's allowed us to partner with groups like Peak Vista and Salud to be able to provide eConsults in the medical homes that are FQHCs, which I really personally, and we're early on in this, but I think that's going to be completely transformative. So rheumatology, we do about 6% of all eConsults that come in. We've done over 3 years, about 500. I think that number's up to about 1,000 since we've gone live with the FQHCs. The outcomes from these eConsults, we typically are able to answer anywhere from 70 to 80. The actual number is 73, where the care is maintained in the primary medical home. The message is, you got this, this is what you can do. Anywhere from 15 to 20% month per month we're gonna actually look at it and say, nope, I can't answer this one. I gotta do a physical exam, I need more data. We're gonna bring that patient in. And of these patients that are converted, when we reach out and get people booked in, what we actually find is that we have a lower no-show rate when we've partnered with patients in that way, but also total cost of care goes down because we're decreasing redundancy. There's about 10% of eConsults that we will put back and say, I can't even answer this because A, it's completely another field, or there's just not enough data to be able to go over. We have great data on PCP satisfaction and also the idea of force multiplication. So if I can have 100 doctors doing what would be frontline rheumatology, I've increased my supply side of the supply and demand equation. So 95% of PCPs have been highly satisfied. 100% of PCPs believe specialist response have advanced their clinical knowledge. That's the force multiplication. 95% of PCPs find eConsults to be easy to use. So there's low barrier to entry. And they've also found them to be highly valuable. Sorry for the background noise. Our projected growth, and I shouldn't say projected by 9/1, I just don't have the most recent data. But by 9/1, we had projected that we would actually have 107 clinics across Colorado being able to leverage eConsults to the university, 553 primary care providers able to access it. Last phase, and I know I'm running long and I apologize, I'll go quick. So we also have been spending the last year doing an ECHO program for primary care, where basically we did 47 sessions that have rheumatology didactic to begin, but then the chance to review data. The current reach of ECHO is literally statewide. I think we've actually filled in 2 more of these states. So I think we're up to 61 of the 64 counties across the state. Sample of the topics we've covered in the last year included a lot of work in the COVID space, but we've also been doing some COVID work in nursing homes to help nursing homes be safe. But we also have regular programming in other specialties beyond rheumatology, including endocrinology, transgender health, ped psych, telehealth. The geographic range for rheumatology was a little bit smaller, but we had 77 registrants, 50 primary care providers participating, averaging about 15 per session. We had a total of 47 sessions over the last year. We had 22 cases presented and 4 patients that had to be seen on site within follow-up back to the primary care provider. The one ask I have for all of you is remember that we're booting another session. So starting on September 26th, we're going to be going back. These are going to be confined actually to what we're going to do is we're going to try to deliver our curriculum instead of 47 discrete talks. We're going to be doing it with just 6. We're going to really compress it down, but then be available during sessions when we're not doing didactic for just straight case review. So our plan for the next year is to continue to expand virtual care outreach clinics, expand access to eConsults. We're really waiting for the state to get the final terms for the Medicaid eConsult plan, because that influences the capacity for primary care to be able to join in and be compensated for their eConsults. Working to improve care transition, leveraging health information technology to really right-size care, right patient, right data, right place, right time. And then critical analysis of value care when non-traditional forms delivery. I think I hit it all. I appreciate that you were able to hang with me during a whirlwind.
Thank you. Thank you. That was thank you for that information.
Thank you. Awesome. Does anybody got anything right now that we need to share?
Duane, if that's okay.
Yeah, absolutely.
I would like to ask one quick one. So, we've been working on the Specialty Care Access Project in Aurora, which I'm about to present on. And so I'd love for you to see those results because rheumatology did come up on our list. My question is, how do we get the work that's being done in the rural places, like you talked about the safety nets and those neighborhoods, how do we get some of that focus in Aurora? So is there a conversation that can be had to get kind of that sort of level of collaboration and thinking for the Aurora community? I don't know what the answer is, and that may be a really ignorant question, but I just want us
It's
to
not
think
ignorant at all. It's
about
a great
Aurora,
question.
just like, and I'll just say real quick, the distance traveled, yes, is a big thing, but an Aurora community member having to take off work and get to campus and find childcare, it's not as different than a rural person growing up as it kind of is lifted up as being.
Well, and that's where I would actually say for Aurora, the modalities that are most relevant for new patients would be the echo and eConsults, and not necessarily establishing outreach clinics. And the reasons are, number one, eConsults and echo are going to be less expensive to no expensive for the patients. But if I'm doing virtual visits, even to a FQHC facility, I'm going to be dropping a bill through the university, and that's a hospital-based clinic. So they're going to be facing more expensive bills than they would if they went and saw a community rheumatologist. So that's one of the weaknesses of academic centers is we are all co-located with hospitals. So that means that hospital-based billing is in effect, which means labs, radiograph, pro time is all markedly increased. Some estimates say 7 to 10-fold increase. So that's why leveraging eConsults and echo actually would improve total cost of care, but then that's identifying only the patients that need to come onto campus. And if they have absolutely no insurance, then partnering with the community, with the primary medical home to be able to say, okay, these are the ways you can do it on site, or yeah, you probably need to see this person, send this person for a one-time visit to a community rheumatologist because they're going to cost a lot less than I am when the bill hits.
Duane, is the training you're doing coming available to all PCPs, and how do we share that opportunity with PCPs we might work with?
Yeah, just send them to the echo website.
Well, if you were all just kind of overwhelmed by Duane's presentation, wait till you see this next one. It's more of a comprehensive exploration of Aurora's specialty care issues and needs. So let me go ahead and introduce Dionisia de la Cerda, who will give just a little bit of background and then start the video from Dr. Carrie Nader, which is part of a big team, not in quantity, but a big team in the quality and their analysis of the issues within Aurora. This is very important study that's been done. Research instructor, associate director, Diversity, Health and Equity, Department of Family Medicine. Take it away, Dionisia.
Hi, everyone. Like Rick said, I'm Dionisia. We've been working on this project for about 2 years, and Carrie has done a wonderful presentation, but it's 40 minutes long. So last night with my very limited editing skills, I've chopped up the video. And so just bear with the choppiness of the beginning. I did my best to remove kind of stuff. I really wanted us to focus on the results. And so the first part, if you're not familiar with the project, there may be things missing, but we will give Aurora Health Alliance the full video, and you can upload that to your channel as a full presentation. And if this is an area that's important to you, I would encourage you to watch the whole thing. But what I'm going to show you is going to get to the heart of it. What Duane is talking about, rheumatology did show up. And so these are the kinds of things where this group needs to kind of get into the trenches and solve these problems. And then just a quick, this is a very number heavy meeting, but I want to remind folks that we are talking about individuals' lives in Aurora. And then is there someone that can share, or Joe, or is someone sharing the video for me?
Yep.
We can go ahead and start it. So it's going to be 30 minutes of Carrie talking, and then we'll have time for discussion after.
So what do you think, everybody? Was that awesome or what?
There's a call to action that comes out of both Duane's presentation and Carrie's, and there's a lot there. So I think our next access specialty care meeting early next year we're going to really, I think, focus on that, I think.
We've got a couple minutes left of time before we let folks kind of digest all the good information. And I think we can, Dionisia, we can share the original longer video link with folks. This info, it's a lot to digest, but it was really interesting, especially having a rheumatology and then going into looking at how that presents through the work through the Access Specialty Care Survey. So thanks so much for all your work with this, Dionisia, you and your team. It's really great information. Okay, well, thanks everyone. Thanks Rich and Molly for co-chairing and getting everything moving along. Thanks for coming, everyone. Have good days.